Hello everyone. What I'm going to show today is what we did in the neuroradiology section at Yale prior to the CT era. Here's a list of all the things that we used to do prior to the CT era, and I'll go through each one of this separately. Now, this is the fluoroscopic unit we used to have at Yale when I started my residency in 1963. However, this is the way the room was when we used to work with the fluoroscopic unit. We could barely see anything. And before we entered the fluoroscopic room, we used to wear these Second World War goggles. We used to all stand outside the room wearing these goggles so we could get accommodated to see in the dark. One big advance was that at the end of my first year of residency, we got the first image intensifiers, as you can see here, and now we could work during daylight. And however, there was a very small, like a 4-inch little mirror that we used to look to see the fluoroscopic image, but still this was a big advance. Spine radiographs. Now we sit in our air-conditioned reading room and looking at the CT images, and we can easily see a dislocated fracture of the cervical spine. But this was not the case before the CT era. Here's a patient from that period. The reason that was important that we had several trauma cases that came in and they were intubated or taken to the OR for some surgery on the chest or abdomen, and then awakened from anesthesia paralyzed because of a missed cervical spine fracture. So all efforts were made to try to diagnose the cervical spine injuries in a case like this one, where we see only a small part of the spine. So we tried the usual, which did not help. And one of the things that used to help, we had these straps, and actually that was the first thing I did when I returned to Yale as the chief of neuroradiology, is to build these, have these straps made. And we used to, myself and the fellows, we used to stand and pull on the shoulders as hard as we could while the films were being done, and that helped several times to see more of the spine. That's why the fellows heard me say that if I only got 2 films, all I cared about was the oblique films, because if we could see the lamina lined up like shingles on the roof, we knew that there was no severe dislocation of the spine. So that was a very helpful image to see. Another thing we used to use is when we wanted to exclude a fracture of the dens, we used to look at the extended waters view in the AP projection. Then you could see nicely the dens here, again to exclude a fracture. Skull radiographs. Why am I showing this image of an increasing stroke? Any of the fellows? Why am I showing this? Correct, mass effect. But what structure am I showing is relevant to this talk? Correct. As Gino says, pineal calcification. Note the increasing shift of the pineal. This was the key structure for us. Remember, pre-CT, that's all we had was a CT. So that was a very important diagnostic tool, because if the pineal was shifted, then patients would have to undergo an angiogram and then taken to the OR if there was subdural or large intracerebral hematoma. So this was the key diagnostic tool that we had. But many times you couldn't see it, or if you saw it, the head was rotated. So there were all kind of measurements that we used to use. I'll only show one where the line was drawn from along the clivus to the tuberculum celer and then perpendicular rays. Here we see a displaced pineal due to a mass displaced posteriorly and inferiorly. So that was very important. That's all we had. Now, because of rotations of the skull, many times you couldn't tell if the pineal shifted or not. So I did a study then. I used dry skulls. I used a BB to simulate the pineal, and I hung it so it would, and then I rotated the skull. Turned out, if you ignore the face and just look at the calvarial outline, even with rotated films, the normal pineal would stay in the midline between these two distances here. And I also then extended that to look at the sylvian line and the relationship to the anterior cerebral artery, again showing when the anterior cerebral artery appeared shifted, if you measured to the true wall of the anterior fossa, that there was no really shift. And also I did it with the internal cerebral vein between the sinuses to show that they were always in the midline, even between the sinuses, even in rotated films. And this also did that for the fourth ventricle. Well, I delayed, unfortunately, for a few years before I decided to publish it. And by the time I got around to doing it, CT came out, and there was no need to publish it anymore because it would be of no value. Nowadays, we look at these supracellular masses and decide what is happening to the cella with ease. But this was not the case in the old days. You could see we had to look very carefully at the shape of the cella. Was it eroded? Was it enlarged? Was it anomalous? That took a huge amount of time. There are tons of paper published to try to correlate it for intra and supracellular masses. Most of them were all useless because we could really never, unless there was obvious erosion and destruction, but the various shapes were not helpful. A sloping floor, there were many studies to show there was no correlation between the sloping floor, etc., and the presence of a lesion. Okay, the next thing that we used to do is pentopaque myelography. Myelography was actually invented in France, where a medical student was sent by the clinician to inject some oily material into the paraspinal region, and the student accidentally injected the oily material into the spinal canal, and when they fluoroscoped the patient, they saw the pulsations. They thought, oh, that's a great way to look at the intraspinal content. So there was a whole series of materials that were developed, and finally the safest material was pentopaque, which we used to use, an oily material which used to be injected into the spinal canal, as you can see here, to outline disc and very other lesions. However, it was hard to use because it did not mix like nowadays. They're water soluble, and they're kind of layered, and you have to kind of move it carefully into the cervical area. Here we see actually a nice cervical myelogram, but notice that it only outlines the dependent portion of the sac and does not surround the entire cord. The worst part of the fellowship was in removing the contrast, which we always had to remove as completely as possible. It was very painful for the patient. All kind of needles were used. Some were dangerous, but there was never a very satisfactory and painful procedure, both for the patient and for the fellow or attending who were trying to remove it. Now, one of the issue was, let's just, like in this patient who had metastatic disease, showing a complete block to the flow of pentopaque at the L3 level. The issue was, what was the upper extent of the lesion? Because that was important for the therapist, especially the radiation, and we could not really tell him. All we could tell him was the inferior aspect of the lesion, but nothing else as far as the entire extent. Now, soon after I came to Yale, I came across, when I was a fellow at Einstein, Dr. Asimov used to do a lot of percutaneous cordotomies for intractable pain, where they would go in and damage the tracts of the spinal cord. So they used to do C1-2 punctures. At the time, I was not interested in that, so I didn't really pay attention to what they were doing. But after I got back to Yale, this paper came out by Dr. Hines, who was actually preceded me as the chief of neuroradiology at Yale, and then left to go to a different institution, and came out with this paper actually showing that he did C1-2 punctures for gas myelography and also for injection of pan-opaque. So I decided, let me see if I can also do that. And turned out, I was quite nervous, as you can imagine, doing the first study, because I never saw anybody else do it. It was just an article I read. Those were the good old days where we could try things without going through HIC and complicated administrative permissions. So this was done with the face down, and the result of that is that we could outline the upper portion where the blocker was, showing the extent of the lesion, which made a huge difference for the neurosurgeon as well as the radiologist. And as the therapist, radiation therapist. Now, it turned out that we could do these studies both in the supine and in the prone position. Now, the key thing was where to position the needle. This is like the last case that I did with Ryan Hernandez a few years ago. The key was that the needle, using the fluoroscopic unit, you advance the needle into the spinal canal in the posterior third of the canal, because this was the safest and you're unlikely to hit the cord. That's just to show you the case that I did with Ryan. That he was very nervous about advancing the needle beyond, but I said, look, we're way back behind the cord. Sometimes the dura gets displaced by the needle. Just put it in, and finally we got the fluid. But note the position of the tip of the needle. It's at the midline. As long as you're behind the cord, that's fine. And here you can see us injecting the water-soluble contrast. One of the dangers of doing a C1-2 puncture, which fortunately did not happen while we were doing those at Yale, was a low-lying pica or an anomalous pica at C1-2 level, which was published. This patient actually developed a severe epidural hematoma and actually passed away. But we were fortunate not to have any of complications. And we did a huge number of these studies, to the point where the fellows even got tired of doing it. The residents on the service used to do it under supervision. The beauty of the C1-2 puncture was the comfort it was for the patient. If you can imagine, we used to have several of these emergency myelograms over the weekend or middle of the night. The patients were very debilitated, in severe pain, and to turn them around and move them around and tilt the table on the fluoroscopy machine was a very agonizing experience for them. So the beauty was we used to put the patient face up on the table and do a C1-2 puncture to look for a block, and the patient were much more comfortable. And basically, I used when I was called to do myelogram, emergency myelogram, to look. All the neurosurgeons were interested in was, is there a block or not? So I used to do a C1-2 puncture, put 3 cc's or 2 cc's of panopaque, tilt the table, and if I saw it collected in the lumbar sac, that was the end of the study. There was no block. So it was very simple, no films, nothing. So C1-2 punctures was an extremely useful new tool that we had. Okay, let's move on to a different study, cerebellopontine angle myelography. Now, one of the principles of doing myelography when you have to run it from the lumbar area to the cervical area is to have the head extended, because then you're dealing with like a U-tube. One arm here, the water will never go higher than as long as you have a U-tube. So as long as you had the head extended, no matter how much you tilted the table, the panopaque will not run intracranially. If you wanted to run higher up, you would have to flex the head as shown in this diagram. So for instance here, with increased flexion, you can see now the contrast running along the clivus. However, if you were not careful, you ended up with this, which was not a pretty sight and had various complications or visual issues if it got to surround there. So you wanted to avoid this at all cost. Now, one of the anatomic structures which helped us to do the cerebellopontine angle myelography was the tentorium. You can see the tentorial opening here, but the tentorium avoided the passage of contrast anteriorly if you had the head tilted. So here's, for instance, where we ran up the contrast with the head tilted, and notice almost all of it is caught underneath the tentorium, just a few droplets which are above it. And here's another study with more droplets, but still the majority is caught in the cerebellopontine angle. And just to show, occasionally you'll see a CT with these high density. This is somebody who's older, who's had a panopaque myelogram with some spillage in the posterior fossa. This is these droplets of panopaque, also in the middle fossa here. So here you can see the anatomy that we could see. You could see the basilar artery, the ica, and some of the cranial nerves. But the main thing was to fill the internal auditory canal. And here you can see like a limited study, and here we can see the IAC filled, even with a crista transversa here. Here's another normal. And here's a study showing an acoustic schwannoma outlined by the panopaque in the cerebellopontine angle. Here's a much larger lesion, a normal for comparison. This is a large cerebellopontine angle tumor. Notice all the panopaque is limited to the posterior fossa, again, because of the tilt of the head. Now, this was a very interesting case that I did early on when I returned to Yale, and when I see all these various collections of panopaque. This was a lesion demonstrated also in angio. What was this lesion? Any guesses? Was pockets of panopaque? Anybody? I made a bold diagnosis at the time, which established my reputation. I said this is going to be an epidermoid tumor. Epidermoid tumors notoriously, when they were in the ventricle on the cerebellopontine angle, had like panopaque caught in the interstices of the tumor. You can see here the tumor here. So this patient was operated, and this was an epidermoid cyst or an epidermoid tumor. So this is one of the few cases you could really make the diagnosis by these pockets of panopaque. as Gino also said, made the correct diagnosis that this was classic for an epidermoid. Some people tried to do air cysternography, but we didn't do that because it was a little cumbersome to do. Okay, one other thing that we studied was myelography, was CSF leak due to rhinorrhea. That was a very frustrating experience. What we used to do is run the panopaque all the way into the floor of the anterior fossa. You can see here. And unless the patient was actively leaking, you really never saw the track into the nasal cavity. But if the patient was leaking, then would work. But still, it was a frustrating study. Plus, you had to dump all this panopaque into the anterior fossa. So, again, only was active, extensive leaking would you see the tract. Okay, now to the big topic of pneumoencephalography, which was really developed by Walter Dandy, one of the giants of early neurosurgery. Here we see, and these are the lateral ventricles here. Dandy already in 1918 published a paper on where they injected air through a ventriculostomy and outlined the ventricular system, and then felt that this was a great way to study any displacement of the brain or the ventricles by tumors. So this was the beginning of pneumoencephalography. He also noted at the time that some of the air from the ventriculography would pass into the subarachnoid spaces. So he thought, instead of doing ventriculography, maybe you could also inject it into the spinal canal. But he did not do it himself. So that brought on the age of what we call fractional pneumoencephalography. Well, they found out that if they injected a huge amount of air to fill the entire ventricular system, the patient did very, very poorly. So they felt that that was a dangerous thing to do. So when I got into doing that, by that time it was called fractional pneumoencephalography, and we used to inject 5 to 10 cc's of air and manipulate the head in different positions to see, like here we saw the fourth ventricle, the aqueduct, in the erect position, face down for the occipital region, face up for the frontal region, and then somersaulting the patient, we would see the temporal horns. So this is what we did. And you could see if you injected air into a baby's ventricular system, by turning the baby around, you could manipulate and film the various parts of the ventricular system. Remember, again, you only want to inject fractionally. And in adults, you cannot like somersault them like this, so these monstrously sized machines were developed to turn the patient completely around. Here's one machine that was used in Italy, and you can see the patient strapped in. This was another machine that was, that's the same machine showing the patient strapped in. This was a machine that I think was at Columbia or Cornell. Again, you can see the size. It took up a whole room. Then things got a little simplified. This was a Roberts chair where the patient was strapped in and was able to be rotated. And what we had was the Memer unit. Now, fortunately, when I returned to Yale as the head of neuroradiology, Kathy came to work with me. And Kathy was an exceptional technologist, and I was very lucky to have her because she without her, things have not worked out well. She was really fantastic. And what we can see here, this is the Memer unit, which is actually developed in Sweden but marketed by Siemens, where the patient was strapped into this chair, and I'll show you later. And this was a image intensifier. We did both pneumos and angio on this machine. It was a phenomenal machine. So here's the beginning of the fractional pneumosacrography. The patient sits in the chair, the back is exposed, and I used to clean the back and put a spinal needle in to inject. Now, initially people used air, but air used to last quite a long time with the patient having many days of headaches. So by the time I started doing it, we were using oxygen, filtered oxygen, and the outlet is still in my office, you could see, because that's where the room used to be. So I do a spinal tap, and once I got fluid, I would inject 5 to 10 cc's of filtered oxygen with the patient in the sitting position. And as you can see here, the key thing was that they had to be slightly tilted forward because you wanted to catch the bubbles of air in the cisterna magna, and gradually then it would enter the fourth ventricle and the aqueduct. If you had that extended, the air would go partially in the ventricles and partially in the subarachnoid space, and that the headache was always relating to air in the subarachnoid space, and it was extremely painful. So ideally you had to have their head slightly flexed, and then you could do the whole study without the patient having symptoms, as long as the air was in the ventricular system. So this is like the first film we got. This was a tomogram, which I'll explain in a minute, showing the fourth ventricle, aqueduct, and the back of the third ventricle, just like this picture here, with the head slightly tilted forward. Now, how we obtained this image of the midline, the machine used to go up and down in a tomographic movement. Now, what is the principle of tomography? If you have a metal ring and you have, let's say, a saw in the midline, if you just take a film, you will not see the saw. But if you turn the image, slightly from side to side, you blur out the ring, and only the saw in the midline will be seen clearly. So that was the principle of tomography. You blurred the sides of the image, and just the center of the image was clear because it did not move. And that's what was happening in the machine. Now, you could also turn the head, or the patient turned the head slightly from side to side without moving it. Here you see the patient having this taped, and the head would be turned from side to side to obtain this image. Now, this is the original tomographic type unit, where you could see the film was resting here and it would swing around. So along the pivot was in the midline, and it would appear clear. Over the years, all kind of motions were developed to blur the sides of the image, and the Cadillac was a polytome, which was designed where we had one. It was a very expensive machine. We used to use it for the temple bone studies. Had this very hypercycloidal complex movement, and you got very sharp, focused images. And some people even used this combination of a chair with a polytome, was another huge, complicated, expensive machine. But we never had that, or needed to resort to that. Again, we got nice midline images that Kathy got by just using the linear motion of the Mimer machine. One of the problems was if you got subdural air, the study was over. See, here's subdural air, because you could not outline the ventricle, plus the patient had severe headaches. And that was usually the result. If the needle was not advanced completely into the subarachnoid space, you would get a partial. First of all, that's when you see on myelography the leakage of material outside the subarachnoid space, but also the air would be partly in and partly out in the subdural space, and then the study was useless. So initially, after we put the air in, we put the head down, and we got a good view of the occipital horns. AP, and lateral. Then we swung the chair around and got a face up to show the frontal horns filled by air and also the anterior third. And here, for instance, is the third ventricle compared to an MR. We got pretty decent views here to look for pituitary lesions. Here's, for instance, a pituitary tumor deforming the suprasellar cistern a little bit, a small tumor. Now came the critical part of the study, where we rotated the patient completely around in 360 degrees. That time, Kathy and I used to always get out of the way because the patients many times vomited when you put them through that maneuver. But that was the only thing you could do to see the temporal horn. And after the patient went all around and it would end up face up, we did the films, and you can see here the temporal horns filled with air. So that was usually the last part of the study because, as I said, the patients many times got sick. We also did little babies to look for tumors and other lesions under anesthesia, and younger patients who had to be done under anesthesia. So this was not a study that you wanted to subject the patient and yourself to unless you really had to. Now, what then we used was the deformity of the ventricular system to tell you where the lesion was. It did not tell you what the lesion was except under unusual circumstances. So here, for instance, the ventricular system showing displacement, which actually was a meningioma, but you could not tell. All you could tell was where this tumor was, on which side, and then when you did an angio after that, then you would get some more information. Here's a large, this was actually an aneurysm in the suprasellar region with marked deformity of the third ventricle. This was a clivus chordoma. Notice the aqueduct and the fourth pushed way back. And this was a glioma of the corpus callosum deforming the roof of the ventricle, and the pericallosal cistern here displaced upward. So this, these studies were usually followed, if possible, unless it was an emergency, by an angiogram. So this was the value of pneumoencephalography, or which we did a significant number of patients. Next, direct carotid angiography. Nowadays, we sit in the reading room and we have no problem diagnosing a subdural hematoma. However, in the pre-CT era, I remember being on call. Every night I used to get called by the neurosurgeon and neurologist, says, we have a patient, he has a stroke, we're not sure if it's a parenchymal or maybe the subdural. So I used to have to come in, and Kathy came in to do a carotid angiogram to rule out the presence of an extraaxial mass. That was before the days of cath angiography, so we did direct carotid sticks, of which I've done several hundred. Now, these beautiful pictures by Netter show the approach, but not exactly correctly. Number one, you had to straddle with your fingers the carotid artery. It was very hard to puncture the carotid because it was always mobile. So you had to put one finger on each side of the carotid, hold it in place so it would not move, and then you were able to puncture it. Another thing was that you had to have the head very extended. And Kathy used to inflate a little rubber balloon that she put under the patient's neck to extend the neck, and the head was a little bit lower, so then it was easy to approach the carotid. But still, you had to be very careful the way you did that, as you can imagine. This is, again, not correct. Once you got flow of blood, you never advanced the needle like that. We had a very short, very floppy wire that I used to insert into the needle, and if the wire moved gently beyond the needle, then I would advance to stabilize the needle. If the wire met the back wall, then I would pull it back a little bit, but never advance the needle without having the wire initially. And that's why a lot of people had difficulty and created severe hematomas of the neck or strokes, because they advanced the needle without having the guide wire in it. Another thing, that this was very bad, I never had connecting tubes because there was always the danger of an air bubble. So this was a straight system without this connecting valve. It was just a plastic tubing directly into the syringe. Another thing I want to point out, this glass syringe, this was extremely dangerous for us to use, because we used to have to push very hard, about 8 to 10 cc's of contrast very fast. And several times these glasses would break, and you have to be very careful. And I remember one of my co-fellows, when I was a fellow, got damage to his hand because of the shattering of the glass. So one of the first thing I did when I came back to Yale is finally they had plastic syringes, and that obviated the danger of the glass syringe. And plus you could never do it like that. You really had to shove with your palm hard to get the contrast to flow in. So again, here you can see the key was to be below the bifurcation. So here's the needle. Patient has a complete occlusion, but remember, with a very floppy wire, you would not go too high, and you could diagnose the occlusion. Now this is the way we did angios when I was a fellow. That was before I got to Yale. That's not me, but this is just a picture I found. There were three, here they show four, there were three cassettes, both for the AP and the lateral. We used to do the puncture. He doesn't wear any gloves, but I always wore gloves. And then either the technologist or the other fellow I would inject, and then a film would be exposed during the arterial phase, the intermediate phase, and venous phase. So we only had 3 films to look at. Later on, when I came back to Yale, and also when I was a fellow, we had film changers. And basically, each film was its own little cassette, and they used to kind of pull out away while it was being filmed. Usually there were about 10 of these in a cassette. Eventually, they removed the cassette system. This was an impossible study to do. To do a vertebral angiogram, you had a needle with a side hole that you kind of put in blindly, hopefully, and this was very hard to do, and we tried it a few times, but we gave up because it was really unsuccessful, and then and dangerous because you could damage the vertebral arteries. So we never did that really on a routine basis. Another study that then came in was brachial artery cerebral angiography. That was the next advance instead of direct carotid. What we did, we took a 16 needle, put it into the brachial artery, inflated, and then we injected 30 to 40 cc's. On the right side, then you would see the carotid and the vertebral artery. If you were lucky, it also filled the carotid, the arch, and you got the left carotid. For the left vertebral, you had to do this thing, the same thing on the left side. The danger of this procedure was extravasation. I remember those were the days of very, ionic contrast. So if you injected 30, 40 cc in the arm, you had all kind of problems. You have to be very careful to avoid sloughing of the soft tissues. So you have to be very careful with the position of the needle. Here's a useless study that which we tried to do. Because remember, there was no cerebral angiography. people wanted to know what's happening in the orbit or in the cavernous sinus. So that's what we had to do. You had to put a band over the forehead and then try to put a needle into the supraorbital vein and then have the patient press on the cheek and the lateral part to get the contrast to flow intracranial. And here's an idealized study showing the orbital veins, showing the cavernous sinus. From a practical point of view, it was very hard to do. We rarely got successful studies, and we were glad when we no longer had to do that. Here's a case of painful ophthalmoplegia. You see that the veins do not fill here, and the cavernous sinus do not fill well. This was a study that we were happy not to have to do after a while. Does anybody know what the Seldinger technique is? Correct, as Gino said. Seldinger technique. This was the most revolutionary thing that happened in cerebral angiography, and that's why catheter angiography became such a popular tool. Seldinger was a Swedish radiologist who wrote up this system after experimenting of the classic way of putting a needle in, putting a wire in, removing the needle, and then putting a cathing over. He became so famous, we always used to talk about the Seldinger technique. It was really a revolutionary development, and all what's being done now is based on this principle that he elaborated. He became extremely famous, a very modest guy, but in a small paper that initially wasn't even recognized, but it made the profound change in angiography. Now, life as an angiographer, which we in the beginning was not easy. First of all, we did not get catheter. What we got was 100 feet of rolled up polyethylene tubing, which was non-opaque, and we had to make our own catheter. So first, we used to cut it. We used to pull to make a kind of and then we would cut it. We would put the wire in, and then on the other end, we had to put it over a stove, which was not always easy to do because they used to get stuck to the hot plate, and then you had to start all over again. So, and then you had something where you could put the adapter on that. So these were our early catheter. And the disadvantage was that you could never see them in the body. They were very soft, they lost their curvature, and you have to have contrast in them to be able to see them. And then before you sterilize them, you used to have to use a kettle with steam to make these various shapes. I unfortunately never graduated beyond the first three shapes. I could not master this very easily. Plus, you used to always burn your fingers from the steam, but that's what we had to do. But once you put these catheters into the body, as I said, they were very soft, and you could not see them without contrast, and we had no heparin. We had to constantly flush. Luckily, the contrast was an anticoagulant. And I remember Anne, who's a chest attending now, who was a resident at Yale, she still remembers how I used to always harangue her to flush the catheter nonstop because of the fear of clotting. It was very critical, either to have contrast in the catheter or flush it. And then, of course, we had to learn the displacement of the vascular tree to tell us where the lesions were or what they were. Now, nowadays, we do an angiogram, we get these beautiful images to middle cerebral stroke, but that was not the case in the old days. We used to get angios to look like that. Here's again a stroke. However, to get this subtracted image, Kathy had to drag to the dark room like 10 cassettes, each one the size of a small laptop. And the way she produced these subtraction was that before the injection there was a film without contrast in it. She would take that film, make a negative of that, then each of the 10 or 11 films she would superimpose very carefully, because once you superimpose a negative over a positive, the bone would disappear and you would only end with the vessels. So each one of the superimposition had to be photographed separately. So you can imagine, we used to spend hours doing these cases, especially if you had an emergency at night, and nosebleed was the worst. You do many runs, so you spend hours and hours doing the study, doing the subtractions to look for small leaks and stuff. It was no picnic. And then angiographically, there are only very few lesions you could identify. Classic meningiomas that I've showed before. Again, this sunburst appearance. Classic glioblastoma multiforme was an early vein or metastatic lesions. But beyond that, we basically just saw displacements or vasculitis. But still, it was a huge advance catheter angiography early on. Now, who are these four scientists who revolutionized neuroradiology? Correct. As Asif says, and Gino, these were not scientists. These are the Beatles. The Beatles revolutionized neuroradiology. And why did they revolutionize neuroradiology? EMI was a electric musical industries company in England that the Beatles made a fortune for. They had so much money from the Beatles that they decided to go into an engineering and produce the first EMI scanner. Okay? This was thanks to the money from the income from the Beatles. So here's a brochure of the EMI scanner, the first one. Who is this? Correct. This is Hounsfield standing next to the original EMI scanner. That's him again. And this is another one of those famous major discoveries made on a napkin. Actually, he made this drawing on a picnic. What he wanted to do, he wanted to see if he could see an object in a wooden box by scanning from different directions. That's how he came up with the idea of a scanner. And here's a diagram of a patient within the scanner. So you see, and this is and this is the images that I remember. These were the EMI images that the neuroradiologist from Mass General, who got the first machine, sent me. You can see the quality of images, but still, you could see the ventricles. Look at the hematoma here. That was a huge, amazing discovery for us. And look at the intraventricular hematoma here. Beautiful. For us then, it was a beauty. And then I wrote the letter. We are proposing that the Yale New Haven Hospital, I wrote this letter, which represent the most revolutionary advance in neuroradiological evaluation of patients. A long story about the danger to pay. So begins a 1973 letter from that would lead to Yale acquiring Connecticut's first CT scanner. That's what I wrote to the chief. He, of course, did not want to get the EMI. He wanted to get a Pfizer because that was touted to also do body scans, which turned out not to be the case. So this was the revolution in neuroradiology. The CT, when we got our first scanner, that's where life changed completely. Remember, we used to come in every night to do an angiogram or some other emergency procedure. That all stopped when we got the CTs. Of course, those CTs you can see were not the best, and each one took about an hour to do. But still, we no longer had to do angiograms or pneumoencephalograms, and the rest is history. And we dreaded when the machine broke down, which was not infrequent because we had to come back. So this is what revolutionized neuroradiology, and many of the procedures that I showed you earlier no longer were used, and the new era has arrived. Thank you for your attention.